given to me is hepatitis delta virus and chronic HDV infection. So I'll be covering my talk under these heading. What is so recent, what has happened, why there is recent interest in this virus, how the epidemiology is changing, something about the viral taxonomy, which is also very recent, the structure replication, the genotypes it has, the natural course, what are the diagnostic markers available and what are the challenges, and what are the existing guidelines, and very little ILBS data to show. Now, what is the recent interest has come up in the hepatitis delta virus? In fact, I was also looking and searching for the literature. Last 1 year is full of literature. The guidelines are getting updated. The global health sector strategy, as you know, has called for the elimination of viral hepatitis, and there are 5 viruses which contribute to it. B and C are bloodborne, and D is considered as a defective virus. And we have to end the 65% mortality and 90% incidence of B and C infection by the year 2030. And earlier it was thought that hepatitis B will take care of hepatitis D virus, because hepatitis D virus is a defective, dependent virus. And that is why global health sector strategy and so the national programs which have been implemented in several countries like ours have not taken any solution for hepatitis delta virus infection from the testing and treatment perspective. But eye-opening are the 2 recent meta-analyses which has come up, and they have shown actually hepatitis D is very understated and the global prevalence is higher. Very recently in 2021, the taxonomy of HDV is also revisited, and there are newer drugs which are available in the market which can control HDV, because HBV control and antivirals to HBV cannot control this hepatitis delta virus. So these are the 2 published big meta-analysis in which has forced WHO and everybody, all the guideline makers, to look into detail about the burden of infection by delta virus. One which was done in 6 WHO regions, and they have stated that there are about 12 million cases with HBsAg positive. The another, which was done across 83 countries, have estimated the burden of hepatitis delta virus infection to the tune of 48 to 60 million, which is much, much higher than HIV. When we are doing so much about HIV, this delta virus true burden is underestimated, and it is 3 or 4 times more than the HIV infection. Now, who are the population at risk for acquiring? This is a bloodborne virus. The route of transmission is similar to B and C. However, unlike B, mother to child is not a very common route of transmission. It is more seen in people who inject drugs, commercial sex workers, men who are having sex with men, co-infection with HCV, cirrhotic patients, HIV. And the important thing is that there are migrant populations staying in high endemic countries, and there is a continuous mobility of these population, like Mongolia and all those sectors, and they can be an important risk to highly HBV endemic areas. HBV vaccination is not implemented in many countries in India, so it came in 2011 as a universal vaccination program, and mother to child transmission for hepatitis delta virus is not very well studied and it's not known. So what are the challenges people are facing across, including the lab people like us, is there is insufficient testing. The guidance is not there. There is variation in available international guidelines, and there is no effective therapy recently. Whatever interferon, that also gives a cure rate of about 40 to 50%, not 100%, and the testing is not adequate. There is a variable estimates from individual countries, as I have told so. Accuracy of those who have done these studies in the past is also challengeable, because the test, we recently have looked into the literature. They are not standardized uniformly. The WHO standard is very, very recently available, although it is there in the last 10 years, but the kits which are available in the market are not standardized again on the WHO standard. And the information, whatever is available for HDV, including from our country, is very, very outdated 10 years back. So one need to look into this problem recently. Now this is more for the postgraduates, the DM students, and that this is a virus. Recently it was discovered by Risotto et al. In 1977, also known as a satellite, incomplete, defective virus. And recent is that this virus was thought to be the only one in the Delta virus family. It has been given a family, Colmioviridae, and there are other Delta-like agents available. So this is a virus which has got a circular RNA, and that is why it resembles viriyoids. Viriyoids are not considered, and especially in the plant, these are single-stranded RNA circular structures, which are considered not very pathogenic because they cannot encode for protein, but this is one virioid-like virus which can also code for a protein. Unique thing is it multiplies by rolling circle mechanism, and it utilizes the envelope host of the other viruses to gain entry. Effective, it's the smallest virus. It is about 1679 nucleotide region, and as you can see that this is the covering of the hepatitis B surface antigen. The virus ribonucleoprotein consists of single-stranded RNA, and it has got two types of antigens: large hepatitis delta antigen and small hepatitis delta antigen. Now this is slightly complicated, but I think the interest should be there because the newer treatment is against the various steps of the delta virus. So it enters so it only takes helps of hepatitis B in entry and release. Rest all replication happening inside the nucleus is totally HDV independent. So if hepatitis B envelope is not there, some other virus envelope is there, this can again be problematic. And so it enters, and then the virus goes inside the nucleus. And there, it forms, unique thing is that it forms two types of RNAs, genomic and antigenomic RNA. Now these genomic and antigenomic RNAs are crucial because one RNA gets converted into small hepatitis delta antigen, and then there is a host polymerase dependent modification which leads to the formation of the antigenomic RNA, which forms the large hepatitis delta antigen. Now there is an importance of this because this remains inside the nucleus while this is the one which can come out into the cytoplasm. This is required only for replication, while this undergoes a step called farnesylation. That is, the lipid moiety goes and gets attached to it, and this then attracts the large antigen of hepatitis B surface, which is required for its entry and effect. So this is, and this step is very, very important because newer drugs are now targeting this antigen and this step of the antigen. Now this is, I wanted to share very recently in 2021 that taxonomy of viruses has classified hepatitis delta into this family, and it is not only the human delta viruses, there are delta viruses belonging to all these vertebrate species which are now existing in the nature. Although the phylogenetic relatedness is far, far different, they are very different clustered together, and the one which is present in the humans, all these genotypes, 8 genotypes are different. So these discovery of these HDV RNA-like sequences has again forced people to think about developing antivirals, because in the future, as you know, that cross-species transmission of viruses can occur. This can be a future threat. When we talk about hepatitis delta virus genotypes, there are 8 genotypes which are available, and they differ very different, very less, 20% sequence differences are there when you classify them. Genotype 1 is the one which is predominant, and it is the one which is serious in infection associated with more fulminant kind of co-infection. 2 and 4, they are milder. 5 is also milder. And there are studies which have shown that certain liking of certain HBV genotypes is also there, like genotype 3 usually co-infects with GTF of the hepatitis B. Although these are just published, there is no scientific evidence to show that this one particular type of hepatitis B genotype will attach only to which one particular, but this is also a theory which is happening. Now, this is again an interesting article which I came across, that the people have tried in the human mice that if hepatitis B envelope is not there, then what all viruses can help. So hepatitis C, dengue virus, they have actually shown it in the mouse model culture that if you co-infect them with these envelope viruses, they can also help the HDV to propagate. So two things important. One, you know that delta viruses are not only human restricted, you have these agents in other animals. Hepatitis B dependence is also challenged, that it is not C and dengue virus can also help, but this is just one paper, so nothing to worry. So what is the natural course of hepatitis D infection? Now, both the viruses, when they infect together, which is known as co-infection, they cause an acute state of infection, and 90% chances the body clears it, 10% only it goes into chronicity. Superinfection is more dangerous because there is already a hepatitis B infected liver over which HDV virus insult comes, and there is a rapid progression to cirrhosis and ultimate. What are the prognostic factors which people have studied across this thing? DNA, HDV RNA positivity, its level not very sure, there are limited literature, that more the level of the viremia, the more the chances of poor prognosis. Genotype definitely 1 and 3 have shown accelerated course of cirrhosis and decompensated liver disease. Co-infection with HIV, HCV has also shown, and hepatitis B genotype C and B, and again DNA HBV viremia has any effect, has not been studied. The other clinical and host factors like older age, male sex, and origin of the virus from the Eastern European countries, use of alcohol, all these are other factors which can contribute to its rapid progression. HDV is known, there are a lot of studies, and this is a systematic review of about 93 studies which have shown that it is associated definitely with the increased risk of HCC. So not only your decompensated liver disease by B, but also the chances of HCC becomes much, much higher, and if it is a co-infected group. This is the diagnostic markers, how they go ahead when you have a co-infection and when you have a super added HDV infection. Now, when both the viruses, they enter the body together, it is the B markers which rises first. Immediately within the week's time, the D markers, that is HDV RNA, rises, and your antigen unfortunately is very, very little amount, and after about 1 or 2 weeks that it rises, and this peaks with the peak of the ALT derangement. So acute hepatitis, ALT is deranged, both B and D RNA markers will be very, very high, and this is followed by the clearance, as I told you, 90%, followed by the occurrence of antibodies, which are anti-HDV total for D and IgM core for B, and the total core for B. Now, when it is a super infection, what happens is that B markers is slightly suppressed, or they sometimes becomes non-detectable. So the peak of serum DNA is peaks with the ALT rise. However, at that time, the hepatitis B markers are much, much suppressed. So you may not find, so sometimes unexplained etiology of in a already known chronic hepatitis B, and B markers like surface antigen and DNA is very, very low. D could be a cause, that is what everybody is saying, because it suppresses B. So this is the three type of presentation if they are both co-infected. Usually the most commonly presentation is that there is a hepatitis delta virus, it suppresses the B which I'd shown you. So you will not see very good markers of B. There will be unexplained damage to the liver, and there will be hepatitis D is responsible. Both can be together, means the B viral load, D viral load, lesser number, and very rare presentation is that B markers are very, very high and D is very diminished. Only one type of antibody is being detected. Now, what are the lab diagnostics which are available? So mostly we depend upon the IgG type of antibody to Delta virus. There is ELISA based, there is CLIA based. Rapid card based assays are unfortunately very, very limited, not available in our country. No good trials have been done, and they tell you about the past exposure. But a very good isolated HDV IgG assay is also not available. Most of the assays are total, and which includes both IgM and HDV IgG. In our lab also we are using HDV total assay, because IgM standardization requires a lot of, as a lab person we know that it has to be a capture antibody, and capture assays are difficult to standardize, and so most of the labs are internationally, now the WHO guideline has also added that it should be HDV total. ELISA based are more standardized. RNA can be qualitative, which tells you about the presence of an infection, but if you want to follow up for a treatment response, it is always a quantitative RNA, which is a real-time PCR. Now the challenges is it also lacks standardization. WHO standard is only recently available, but that is also genotype based. More studies available on genotype 1 of the hepatitis delta virus. We really don't know which genotype is there circulating in our country, and we need more so that the uniform reporting in terms of international units can be there. IgM assays, though, can tell you about the acute infection, but they are difficult to standardize because it requires a capture technology from you capture ELISA. Genotyping, not much of the information, usually sequencing based, and the other hepatitis B markers like HBsAg, anti-HBs, which are being used across the labs. I could not find very good meta-analysis or studies, only one where they have actually a French national quality study which was done, and WHO guidelines recently has also taken this reference, where they have shown that they have done a external quality control program across the labs, and they have shown that serological tests have performed better, but look at the pan-genotypic variation. So you will see the concordance across the genotype is so poor, and to about, for genotype 8 it is 5 out of 11. So this shows the lack of good diagnostics which are available, which can cater to all or pan-genotypic hepatitis delta virus infection. Another systematic review which is published recently in 2023 have also focused this problem, that because of this diagnostic variance which is available, lack of standardized assays, the problem is understated, and we really need to work upon this if you really have to tackle the problem. What does the guidelines, what are the literature regarding the international guidelines? ASLD and APASL has only updated in 2018 and 16. The recent one is the WHO in the recent APASL meeting. I think Sir is sitting, can update us about APASL more, what they are thinking. But ASLD and APASL both, so there are two types of screening, targeted and universal. Targeted means you only target to high-risk population, and hepatitis B if it is undetectable DNA and there is unexplained high ALT, and that's ASLD APASL. However, EASL last year has said it should be irrespective of hepatitis B, low DNA and high ALT. All HBsAg should be screened for hepatitis delta virus, total IgG, if IgG available, or total antibody, the screening should be done, and then confirmation should be done by HDV RNA. Recently, WHO last month has updated that universal screening should be done. If resources are limited, then targeted, but it should be a reflex testing for HDV RNA based, lab-based reflex testing. So the reflex testing means that as soon as a lab receives an HDV IgG positive report, they should immediately go and put an HDV RNA to look and communicate. But again, the resource, the cost effectiveness, all this needs to be, this is just a guideline. Now more data needs to be done, that how they can be actually implemented in the public health sector. So the WHO guidelines I just read. They are very, very sorry to state that they're very weak. They just mention that HbA1c positive, do HDV total, do a reflex HDV RNA. EASL guidelines are more comprehensive because they also give you a guidance that whom to treat and what should be a follow-up test on treatment and how frequency of your follow-up. So I have taken it's in bits from here and there and try to make some algorithm. Ideally, you should, if there is a hepatitis B, acute, if there is, so we can divide it in acute and chronic. So if you think that there is no demonstrable past chronic hepatitis B, recently there is acute hepatitis B is there, then you look for a core IgM of hepatitis B. If it is positive, also check for an HDV RNA. If RNA is positive, it can be a acute HDV infection, and if it is negative, it can be, this HDV RNA is negative, it can be a simple, and IgM core is also negative, it can be a simple chronic. Now if it becomes a chronic HBV with elevated ALT, then you should go and test for HDV antibody positive, do whether clinician initiated or reflex by the lab, this has to be decided, do an RNA at least, because if there is an RNA, they should all patients with chronic hepatitis delta, means a demonstrable RNA, they should be considered for treatment. And the treatment option is pegylated interferon. Again, the duration which should be offered differs from guidelines to guidelines. And RNA, once a patient is put on treatment, then it should be at least quantified 6 monthly during treatment, and whenever you have a clinical indication to do so. These are the treatment options. So interferon is one. Recently, European Medical Association EMA has allowed this bulevirtide as a treatment option for hepatitis delta virus, and they have released, the EASL has released these guidelines that it can be used. Otherwise, liver transplant is another option if it is a very aggravating course of co-infection. In the transplant recipients, one person has to, this is what is that because your hepatitis DNA negativity cannot control the recurrence of HDV, so you have to give a lifelong immunoglobulin prophylaxis along with the nuclear HBV DNA suppressor. So that, those things, because D replication only requires the surface antigen of B, so you have to give an immunoglobulin lifelong. This is one thing. Otherwise, there are again, there are a lot of studies are not available. What have people done about the transplant? How do you follow up the HDV RNA? As I said, that should be done 6 monthly, and RNA should be done at the end of the treatment. HbA1c testing should also be parallelly done, and if possible quantitative, because quantitation will help you because it is not only the intact surface antigen of B which can help in its entry, even the empty particles, incomplete spherical and rod-like particles, and we know that HbA1c is secreted by integrated DNA. So, and the amount of HbA1c versus DNA in a hepatitis B infected is much, much higher. So, you need to quantify HbA1c also, and these are the guidelines. The newer therapeutic targets which are available, as I told you, is the entry receptor blockers and modulators like lambda, interferon, pegylated interferon. One prenylation inhibitor, which is the lonafarnib, which is available and it is in the phase 3 trials, and some nucleoside polymers which further prevent the release of HbA1c have been trialed. Only one drug, that is this bulevirtide, is available in Europe country only. From India, we have very limited data available, and all is, as I said, is very outdated, and and they have shown, okay, so before the hepatitis B universal prophylaxis, the prevalence in some has been reported to be 30 to 40%, but it's so variable. And the last 10 years from 2015 onwards, and even we published it, that we did not see any case of hepatitis delta virus. However, we only are testing in HBsAg positive. This is a paper we published in 2018, and we studied 6 months data, how many, because we are not routinely doing these tests of HDV, IgG, and IgM and RNA. So we just, as one of the PDCC students' thesis protocol we did, and we could only find one case, and that case had both the HDV viremia present. DNA was very, very low. However, we could not find out that whether it was a co-infection, acute co-infection or a super infection, and it had accelerated course of fulminant hepatitis, and the patient was died. Then I tried to look at how many tests we have done. In our center, we only do clinician-initiated testing, and so the request in the last so many years is only 137 IgM, antibodies 74, out of which 5 came out to be positive. However, 3 of them were foreign nationals, 2 of them belonging to Mongolia, and 1 from Africa, and only 2 Indians are there. But since we are not doing HDV RNA, it has been outsourced, so I don't have information. Only one recent, which Dr. Manoj has referred to our lab, we did a reflex RNA testing and turned out to be RNA positive, 3 log RNA positive. So I think adoption of these guidelines, so national guidelines are not telling us to do anything, so we cannot immediately start. So I end my talk that hepatitis delta virus, it is associated with most severe form of viral hepatitis. Its prevalence is understated, and it is problematic. There are no satisfactory treatment available right now, so more research to understand the pathogenicity of the virus, as well as the more antiviral target should be done. The national guidelines need to be updated. We don't have any recommendations, so we are not doing the testing. We at least have an HDV RNA and a total antibody kit available in the lab, but most of the labs across the country, they don't have. And I think rather than targeted, the routine screening of all hepatitis B infected should be done. And WHO has taken out these recommendations last month, but it really, I found the document lacking in terms of whom to treat, what should be done following the treatment, what should be the duration of treatment, the treatment, is it genotype specific, and again, as I said, lack of standardized assays which are available in our country. Thank you.